Can you hear us?
Hello?
Hi.
Can you hear us?
Yes, very
Dr.
nice.
Tyagi?
Very well.
Yeah, we have a patient, 46-year-old male, who presented with unstable angina.
Needs to be.
Angiogram showed a LED D1 bifurcation lesion.
Can you show the baseline imaging?
We are going to show you the angiogram. Please show the angio. Yeah. Can you see the lesion?
The baseline, the first one.
We see you, we don't see the, yeah, now we have.
Now we can see the films.
Now you can see?
The first one.
First one.
The diagnostic.
Yeah. I think this is the severe stenosis in the mid LED and you have a diagonal. Can you see that?
Yes.
Very clear.
Now we lost your voice. Now we cannot hear you. I hope that you can hear us and see us.
Continue speaking.
We see and we hear loud and clear.
Dr. Goran speaking. Can you hear me? Ah, okay, perfect. So now we can hear you as well. So as expected, we have here bifurcation lesion. I hope you can see angio. Can they see the angio?
Yeah.
So we have really diffuse disease in the mid-segment of the LAD with large diagonal branch, and there is, as you may appreciate, most of the disease is proximal to bifurcation. But then you have bifurcation segment which is also involved, and you have tight osteal lesions in both distal LAD as well as first diagonal. We discussed here the strategy, and because of relatively short lesion in the ostium of diagonal, we decided to go with provisional one-stent strategy after predilatation of both LAD and diagonal.
Next.
Next image. So we used two Renato wires. Was very difficult because of enormous plaque burden in front of the carina. Was difficult to position wire in distal LAD, but here you may see two predilatations, first in the LAD with 2.0 by 15, next. And then after that we predilated also diagonal. I predilated diagonal because there is really very tight lesion. I hope you can appreciate that one. Even after predilatation, it's still clear evidence of the osteal lesion. So now we are at the moment waiting for you to connect to start by stenting LAD. And because of diffuseness of disease...
Stent, please. Huh?
No, stent is here. I was waiting to discuss with panelists and with our chairman if they agree with our strategy. Any comments or suggestions?
Did you consider the bulking technique in this situation?
But you know, we predilated with 2.0 and balloon fully open. So because balloon really fully open, I was thinking that maybe it's enough if we just predilate with balloon and then post-dilate with non-compliant balloon.
Moreover, the patient is also young, so we don't expect too much of calcification, if I'm correct. Age is 40 years, right? The patient is, what is the age of the patient?
46.
46. 46, right. So,
46. So maybe
we are going to select a long stent,
Continue, I think.
right from the, just after.
we decided to use, long stent, 2.75 by 30 in order to cover also proximal part of the LAD, which was really diffusely diseased in a long segment. And you see it's moving with some test.
Dear Karnan.
Oh, sorry. So this is a resolute integrity, 275. Test. I think should be okay here. Huh?
So angiogram, do an angiogram first.
Do an angiogram. Yeah,
Fine.
I think it's fine.
Yes.
Yeah, so we can even move it 1 millimeter back. Okay. Sorry? Yes, I would like to jail the wire. Yes, up.
उस पे निकाल लो आप. वहाँ से मैं
It's
दिखा
very
देता हूँ. उस पे निकाल लो.
important to go with slow inflation
जाएगा?
and then hold balloon more.
हाँ, किस पे?
10, 12. Okay.
हाँ.
And then to hold the inflated
आ
balloon
रहा है?
for at least 25 to 30
Okay.
seconds if possible, if patient tolerates.
What is the pressure you have deployed this stent? Resolute integrity? What is
Now we are at 12 because 275 is little bit oversized distally. There is
Down
big
कर लो.
diagonal
Down कर लो.
down.
Down कर लो.
There is a large diagonal branch, so there is mismatch between the proximal and the distal part of the LAD.
Fluid fast कर दो.
Okay. Any comments?
I would like to ask you about your ideas about tapering stents that are available nowadays with a different diameter, distal to proximal. Is that something that you consider
Yeah.
valuable in this particular scenario?
But maybe not in this specific scenario because there is, okay, pressure is good. I'll make now angio. Because it's not that
जैसे ही बंद करेंगे
striking
ना,
difference
मैं
that
यहीं
may
आप वहाँ से चालू कर देना
require
और मैं यहीं खड़ा खड़ा बोलता जाऊँगा.
tapered
क्योंकि मेरे को
stents.
feedback
But stents, can we give some nitro and then test? But in vessels with very diffuse disease, if you are using very long stents, maybe those stents with taper tip are decreasing the diameter by 0.5 millimeter proximal compared to distal. May be an issue. So we implanted stent. Now we will make angio to see how angiography looks like now. Ready?
Yeah. Good result.
Okay. So please let me know your comments now.
Well, I think you have some work to do. First of all, you need to expand the proximal a little bit more, and you have to
Yes,
do
yes,
some
absolutely.
kissing balloon.
Yes,
But the initial
yes.
result is great. Little more work, and you will have
Yeah.
perfect results.
Our strategy, yes, absolutely. Our strategy is now to do proximal optimization, as you nicely suggested. So we'll take short but bigger non-compliant
Three.
balloon, and first
Three balloon.
we will open proximal main vessel.
NC.
Then we will go with the balloon in the side branch. After exchanging wires, we'll go and open side branch ostium, and we will finalize with final pot. So if you want, and if you agree with that strategy, pot, side branch, pot, we can continue work, and you can go to another lab if you prefer.
Yeah. Can you show that?
Yes.
सुनो इधर आ जाओ.
Do you agree with that?
Yeah, we
Pot,
agree. I
side
just-
pot.
Have one question about
Okay.
when is
Thank you.
your
इधर आ जाओ. इधर आ जाओ.
Yes.
ये दिखाओ.
what is your preference for side branch wiring? Do you have any specific wires that you would like to use and specific wires that you would like to avoid in,
इधर देखो. इधर
in
इधर.
such scenario?
इधर इधर. यहाँ पे.
If I work with the workhorse wire, in this case,
दिखाओ.
I work with Renato from
ये आप साइड से
Terumo,
जानशु.
from Asahi, sorry. My workhorse wires are run through from Terumo, and I try to finish procedure with Renato only if
वहाँ
I
से
have
angio दिखाओ ना.
difficulties with the
दिखाओ.
workhorse wire. Today we have two Renato wires because there is no, at the moment, run through, and we are working from the
शुरू से
beginning,
शुरू से
so I don't
शुरू से दिखाओ
expect
फर्स्ट से.
that we will have severe difficulties to rewire, especially after recrossing after pot, because proximal optimization should deploy stent better proximally and should open access to that diagonal.
Yeah, what you are seeing now on the screen is a patient, 26-year-old male, who presented with severe hypertension.
We have
On examination, he had a systolic and diastolic murmur in the aortic area with severe hypertension.
Test.
He was diagnosed to be having a case of coarctation of aorta with bicuspid aortic valve.
I'll make
And
C
now we'll show you the, we did the CT angiogram of this patient, which showed a very tight
Now we
quark.
play.
we have a interference from another
Yeah.
cath lab,
More.
so
14, 16, okay,
एक मिनट होल्ड कर लोगे?
with the late proximally. Okay.
एक मिनट होल्ड कर लो.
Oh, sorry.
I'll finish this off. Just fast. You can see the angiogram of this patient. This shows tight coarctation of aorta, which is a tortuous quark. This has a proximal diameter before the quark of 18 millimeter. And there was a small aneurysm just below the quark. So we selected a Cheatham covered stent 18x4 for this patient. You can see the angiogram. We passed a 14 French Moulin sheath, and through which we
Can you
passed
give us the third wire?
mounted covered
The
Cheatham
third
stent.
wire, one more. BMW is okay, but
Next.
any wire that you give.
We positioned across the coarctation of aorta. Next. Can you show it the next? Next karo first. Yeah. This is the stent which has been expanded with a smaller balloon inside. After expansion with a smaller balloon which is inside, we expand with a larger balloon outside. After
This is
confirming the
pilot,
position
no.
of the stent.
No pilot.
The position is very
I
good.
don't want pilot.
Next. And now the stent has been implanted. You can see the coarctation disappeared
150 is, sorry?
and very well dilated quark.
Yeah, but give us whatever wire you are using.
There was 60 millimeter gradient before the implantation of the stent, and after implantation of the stent, the gradient totally disappeared. This is the stent that we used. This is a covered mounted CP stent. It is a platinum stent which has a rounded edges. So the chances of injury to the aorta is very minimal. And long-term results of the stent are also very good. Yeah. Now we proceed to the. Can you show the final angiogram of this patient? Final angiogram.
14, 16.
this contamination is not from here, it's from the transmission.
This is the final stent in the anteroposterior view, very well dilated stent, and we have done the proximal inflation so as to oppose it well with the wall of the aorta. Thank you very much. Patient is fine now. Thank you. We now proceed with the coronary case.
Thank you.
Yes.
So you can see this is the bifurcation, and we are doing proximal optimization.
Thank you.
This is a 3O balloon?
Yes.
Yes, this is 3O16 atmospheres at 3 different levels, starting first at the carina, trying to position distal marker of the balloon exactly at the carina site. Now there are 2 different ways. After performing pot, we can either take a wire from the LAD and pull it back, but if you want to be perfectly safe, you can take the new wire, and we'll take new wire because it's a really young patient. We want predictable
New wire.
outcome. It's already here. So we will make the curve which is slightly longer than 3 millimeters because proximal optimized segment is at the level of carina at least 3. And we need curve which is longer than 3 if we want to cross through the struts. And when you jail the wire, there was a
Focus here.
question.
Focus
It's
here.
a BMW.
Zoom. See how to make the curve.
Yeah.
The secondary
You
curve.
have to be very careful and very gentle. Otherwise, you can break the core of the wire. So take your time to prepare the tip of the wire.
And which is this type of wire you have now?
If you, it's BMW now.
Yeah.
I don't know if you can see it. And what is the goal is to go first distally across the carina inside the stand and then pull it back, and with the pull back maneuver try to enter into the most distal strut. If we jail wire, like in this case, by jailing wire, you can really have a good marker of the location of the carina. We try to go with inside the stand with a loop, not to go behind the struts. Cranial.
Very nice. Dr. Neber, any concern about leaving the side wire, which is
Yes.
jailed before you have a high pressure inflation of the proximal part of the stent? Or that's something theoretical?
Thank you for
because-
that question. It's one of the most frequent questions that we get. Jailed wire is really potentially dangerous, mostly in cases if you have a lot of calcium or a lot of diffuse disease. Here in this case, I agree we have tight lesion, but we don't have much of the calcium at the ostium of the side branch, neither in the proximal part. So it's important to take some time, and you see after POT, it was relatively easy. I don't say easy, it's never easy, but if you are careful and you are planning the steps, now we can cross the distal strut based on the marker, which is a guide wire that was jailed. So please put now torquer on this wire, and we will remove now wire from diagonal, which is jailed one. So I can show you, is that the wire? Yeah. No, keep the torquer. This is what I want to show them. Yeah, what I usually do, I try to disengage the guiding catheter. Please focus a little bit on this side. And then by gentle rotation, hold the guiding catheter for me. It's going slowly, but it's important not to push too hard, and it's out. So next step is to use new one. Please give me new 2.0 balloon. Or I think you can give me 2.5. We try with the short 2.5, 2.5, 15. Maybe we will be able to cross. And after recrossing, we will open struts towards the side branch.
Yeah.
We make angio if result is acceptable. Is
Yes.
this diagonal? Yes. If result is acceptable in diagonal, we will repeat final pot.
Yes.
And there was a study done in France in 100 patients. Dr. Gérard Finet is the principal investigator in that study, because based on bench testing, the best results are achieved with the pot, side branch inflation, second pot. And they repeated for the first time in the clinical conditions, study in 100 patients, and in that study they showed that actually they replicated the results I put little bit of pressure and you see 2.0 new one crossed, 2.5. So now we will inflate slowly, slowly because I don't want to dissect. 6, 8, 10, 12. I'll make a scene, deflate. Now it's important to evaluate the result because I don't want to have dissection. And this is the moment when you evaluate result after post-dilatation at the ostium of the side branch. And this is the moment when you can make decision if you need second stent, hold the balloon.
So you're not planning to do kissing
So we will
balloon?
make angio now. No, I wanted to, let's first see how it will look like. If result is good, can I do cine? Aha, guides outside, sorry. It's better
fine
now.
now.
Okay.
Cine, cine.
Cine.
This is good.
So I think it's good. It's around 50%. There is significant plaque, definitely. But with that plaque, if you continue to increase above 2.5, I'm afraid we will dissect the whole segment. We will need to put a stent. And we have TIMI3 flow. And personally, if you agree with me,
Very
I
good,
think
sir.
result is good.
Very
So
good.
I will just do another pot at that segment to reopen again stent in the main vessel.
3.
What's the
This is
rationale?
the philosophy behind side branch. Pressure was 14, and you know, by continuing increasing, you have to finally dissect. Because in the beginning, if you remember baseline angio, there was significant amount of plaque all over bifurcation with some not very high degree of calcification.
Yes, but is there any rationale why
So
not
after repeating
doing
this spot,
kissing balloon angioplasty for both the main vessel and the side
why not
branch?
doing kissing? Yeah,
What's the rationale behind that?
okay, we can do kissing if you... rationale is that based on the bench testing results, this will not go easily. Okay, inflate. Rationale is that based on IVUS and OCT evaluation, first in the bench testing and then in clinical study, opening towards the side branch, and stent malapposition is significantly lower if you do pot side pot and not kissing balloon inflation. Another one? Higher? 18. So we have non-compliant balloon, we can go to 20. Okay, deflate. Okay, I think we can remove the balloon. Two wires crisscrossed. So let's, if pressure is okay, let's give some nitro. We are giving now 200 mics of nitro. And now we will make angio. Wash. Okay, ready?
Excellent result.
So I think in the LAD we have really, I agree, excellent result. We have still lesion in the ostium of diagonal. So we can either do kissing or finish with this one, having in mind that we have T3 flow. What would you suggest? What would you suggest? You
I
are
think
experienced. It's fine like
Yes,
this.
absolutely.
Okay.
Can you give us an LAO
Let's have the
cranial?
opinion of the panel.
I think the
Cranial.
result is very much acceptable.
LAO cranial angiogram view.
Yeah. Oops, sorry. Okay.
Good, good.
Yeah, I think it's good.
I think it's excellent, huh?
What do you think? There is eccentric plaque at the ostium, but I think LAD looks very acceptable.
I think it's
And
good.
there is no dissection in the
Good to buy,
diagonal branch.
Yeah,
I think
You
the
are
result
happy with
is
this result.
happy.
perfect.
Okay.
Dr. Goran,
Thank you so much, and
Yeah.
I think,
yes,
Yes.
we thank you, and we have noted 2-3 important teaching points from this case. Number one was when the
thank you very much. I always,
yeah. But when the osteal disease is minimal, you have to have a provisional strategy, number one. And number two was to
exactly.
take care of guiding catheter when you take out the guide wire from the jailed guide wire from the side branch, pulling it out and rotating the guide wire with the help
Yes.
of torquer. That was a very important teaching point for all of us. And last but not the least, pot, side branch and pot instead of final kissing. That according to the
Yeah,
latest
instead
studies.
of
I think
kissing,
that was,
yes. I
another
wanted to
important
show you this,
Thank you
and
very
we
much.
can, and we can discuss tomorrow in bifurcation session. Thank you very much, and
Thank
see you
you.
soon.
Thank you.
Thank you.
Thank you.